Yeah, I think we're good to go. I think there's a couple of people still joining. I think by the time we're sort of ready to present there, most people should be here. I must say I went through all of you guys now that has joined, and then no pressure, Nicole and Yaria, but I'm thankful I'm not presenting. There's a lot of people that know a hell of a lot about CML that's joined, so it predicts for some good discussion. Yeah, so welcome to Deep Dive, everyone. Thanks for joining. Those of you who don't know me, I'm Hannes. Asked to chair this session, and today's about CML, first-line therapy, from diagnosis to deep response, optimizing first-line therapy in CML in chronic phase. Obviously, a different ball game if it's gone further down that spectrum. But for now, for today, it's about chronic stable phase. Trying to go to the next slide. Doesn't seem to be working. Next. Good, sponsored by Novartis for today, so thank you so much. Next one. Oops. Hey, Yaria sharing her screen. Everyone's seeing your emails, Yaria. Let's give it a minute to sort that out. Yaria, can you hear us?
Hi, Hannes. Yes, I can.
We all
I'm
seeing
just.
your outbox or your inbox, your Outlook inbox.
Oh, okay. Sorry. Let me get to my
Promise I didn't
screen.
read anything.
Then when it's your time, it's my time. Then you can share it.
Yeah, maybe you must just hang tight for now, Nicola. Maybe Nicola must just share the introductory slides again.
Okay, it's fine now. Can you see my slides, Hannes?
We can, but we haven't gone through the
Oh,
introductory slides yet.
oh, sorry. Let me
No
just
worries.
stop.
There we
Do you
are.
want me to stop sharing?
Yeah, no, it's fine. We're all good now. She's bumped you off.
You can
Housekeeping stuff.
just zoom
Uh,
through them. Yeah.
yeah, it's recorded. Please interact. Please ask questions. Um, CPD points, you must attend for at least an hour, have your MP number correctly in the details. There's a mailing list that you can join, and please give feedback. Yeah, obviously these are the two speakers that's going to speak, and there's going to be a Q&A, and then we're going to just briefly close at the end. Right, Dr. Nicole Holland is going to talk first. She's a pathology expert, senior consultant and hematologist and head at hematology at Lancet. I'm not going to go through everything in detail, but she's got extensive experience over more than 2 decades in both private sector and state sector, and obviously has seen a lot of patients with CML. And it's obviously I think CML is a disease that fits spot on in the interests of identifying diagnostic trends from case assessments and advancing practice through multidisciplinary approaches. So we're looking forward to what she's going to share and all her expertise just from a lab point of view. Next. And we all know Yadia Maharaj. Yadia sort of gone full circle, many units in South Africa, MBCSP at WITS, did the MET, Stellenbosch University, certificate in clinical hematology in KZN, and has now gone back to Joburg, where she took over the heme team from Karen Gunther, and renamed it Ray of Hope Hematology. And she's really made it her own, and we're very excited to see what is going to happen there at Olivedale. And we also wish her all the best there, and glad she's found a place there. Yeah, Yara is obviously a very dynamic person, and we look forward to see what's going to happen there in Joburg. Next slide. That's next week. Transfusion thresholds for those of you who were at Deep Dive this weekend. Obviously, chatted a lot about transfusion and not really a lot about the hematological malignancy field, but more about around surgeries and things. But obviously, low HP can influence therapeutic apheresis quite a bit, and important to optimize the hemoglobin prior to apheresis. But where are those thresholds that you need to wait for, especially given the detrimental effects of transfusion? So that's next week. And now, Yadia, you can share your screen. Is Nicole, you going to speak first, or Yadia? Yeah, Nicole's sharing first. The floor is all yours. Welcome.
Hi, everyone. Can you hear me?
Yes, we can, and we can see your
Okay,
screen.
great. Thanks very much. I'm just going to try and share my presentation. There we go. So thanks very much for having me speaking. And yeah, I'm really looking at chronic myeloid leukemia really from the basics and under the mic, really what you would see, how you would make the diagnosis along those lines. And I'm going to leave the treatment sides to Yadia as the treating physician. These are two patients that presented to Yadia actually at the Olivedale practice. So both patients are an example of chronic myeloid leukemia in chronic phase. So no surprises that this is what they have, but they present very differently. The first patient is more what you would classically expect as a CML presentation. This was a 39-year-old woman who had a really big spleen and a marked leukocytosis, no lymphadenopathy at presentation, and complained of fatigue, and she was really a tired patient. While the other patient, this was a totally incidental finding. She was a 72-year-old woman who had a persistent marked thrombocytosis. It was purely incidental, and she had no hepatosplenomegaly or lymphadenopathy. Now, these patients presented within about 1 or 2 months of one another. And just to highlight their differences, I'm showing you the full blood count, which is, of course, is the part of the case that I really enjoy. So patient 1, our younger lady, she's very anemic. Her hemoglobin is 7.8 with a normal MCV. And you can see her platelet count is normal. But what's absolutely striking is this massive leukocytosis, which is really what we tend to think about when we're thinking of chronic myeloid leukemia. And with the differential, the marked features are a prominence of segmented neutrophils, so segmented granulocytes at 29%, but also you've got that myelocyte bulge of 36%. So really classic sort of differential count that you'd expect with CML. And you can see she's got an absolute basophilia as well, some nucleated reds that are present. So based on this count, one would really expect a left shift, massive leukocytosis, anemia. CML would be very much on your differential, no monocytosis to try and suggest that this might be something else. Now, if you look at patient 2, our older lady, she's got a normal hemoglobin, but a massive thrombocytosis. So she's at 1,286 times 10 to the 9 per liter. And her white cell count is within the normal range, as was her differential count. Everything here was normal. So she really presented with an isolated thrombocytosis, which is unusual, but quite well described in chronic myeloid leukemia. So just taking you through the slides of our first patient. This is a low power view of the peripheral blood slide. And immediately you can see that this has got a leukocytosis. For any regs present, whenever you're looking at counts, you need to look at the counts and then look at the smear to make certain that that marries up and you don't have a swap sample or something funny going on. But this does fit with it. There is a sense that you're looking at a range of different cell types. This isn't a monomorphic picture. And if you go onto a higher power, this shows certain classical features. So we have got the prominence of recognizable segmented neutrophils, which we anticipate. And in addition, there's a prominence of myelocytes. You can see the number of myelocytes in this field. In addition, the basophilia is apparent. And I really want to highlight the importance of someone who's a good morphologist or someone who's an experienced CML differ when you're coming to looking at basophils, because sometimes we do find that our technologists who don't see a lot of these cases actually don't count the basophils at all. And they do look slightly atypical to the normal basophil. You can see how hypogranular these basophils are. But if you differentiate them from the neutrophil, they're not quite as symmetrical. They're not quite as condensed. They've got a little bit of a shabby nucleus. And you can see that there's these histamine-filled granules overlying the nucleus as well, which are features of a hypogranular basophil, such as you see in CML. Another thing, just as you would be telling a registrar, don't overlook looking at your red cells just because the white cells are very exciting, which they always are in CML. And you can see here you've got teardrops present, you've got some elliptocytes, which might be a feature of the massive marrow infiltration that we're dealing with, or that there might be some suggestion that there's fibrosis here as well. And so look at all the cell lines. Just a little bit of a higher power view with very similar features to those previously described. But again, I want to just highlight these abnormal basophils. And if you look at the cytoplasm, almost looks as though you can see these tiny little vacuole, sort of slightly empty cytoplasm in comparison to the cytoplasm of an associated neutrophil. And though it didn't come out in the differential, there were blasts present on the smear. And this is a blast over here. There's a blast over there. This one's got a little bit of blibbing, which might make you wonder, is there some sort of megakaryoblastic differentiation? But it was not a prominent feature in this particular case. Now, with this patient, her bone marrow aspirate was a dry tap, and frequently our aspirates aren't great quality in CMLs, mainly because sometimes with their very, very high white cell counts, we don't get a good draw. But if you look at the trephine biopsy in this lady, something is very apparent, is that besides the marked hypercellularity, I mean, you can see that there's no fat spaces left here. They've all been sort of replaced by this very, very cellular marrow. But you're also getting streaming of cells, which is present, which suggests on H&E that there's significant fibrosis, which would have also been compounded the difficulty of getting a good quality sample. And a higher power, there are features which are characteristic of CML present, which is that widened paratrabecular seam of granular poiesis. So instead of just seeing normal granular poiesis is always hugs the periosteum, and you see it maturing towards the center of the expanse. What you can see here is that the number of lines of maturing granulocytes go well over 5, 6 layers before you start getting mature neutrophils. This is something that is seen in CML with a granulocyte hyperplasia. The other factor, which is very characteristic, is these small megakaryocytes. So as opposed to the other myeloprolifs, where you more typically see a range or very, very large or atypical bizarre forms, the type of megas that you classically see in CML are dwarf megakaryocytes, not as small as micromegakaryocytes, so not the size of blasts or promyelocytes, but monolobed and definitely that sort of small size. You can see there's another one over there. The other things that you can see on this power is that there's a prominence of eosinophils coming up with the salmon pink sort of refractile granules that are present over there. And you can also see a larger number of storage macrophages. Often these macrophages give a sort of pseudo-Gaucher look, where you have sort of a watered silk appearance to the cytoplasm. And that's just because these macrophages are engulfing a whole lot of cells. You can imagine the volume of cells, the burden of cells that they are processing, and you can get the presence of storage macrophages. Here again, here's another example of a storage macrophage present. Just to show you the reticulin stain, and you can see in this particular case, it's significantly raised. If you were looking on the 0 to 4 scale, you're looking at 3 to 4, maybe 4. If you were looking MF2 potentially, reticulin fibrosis, and about 30% of CML in chronic phase can present with significant marrow fibrosis. This is a CD61, which we use just to have a look and see at the megakaryocytes here. So it highlights megas, also platelet clumps and clots which might be present, but it certainly gives you an impression that the megakaryocytes aren't increased and that they are small. So we're looking at small megas here. So that's really the first lady. But in contrast, let me show you patient number 2, who's our 72-year-old. With the marked thrombocytosis, the suspected diagnosis here was really essential thrombocythemia, and that was what the consideration was going into it. It was an incidental finding, the thrombocytosis. And if you look at her marrow, this is her aspirate, it was a good draw. You can see a cellular, mildly hypercellular for age, particle, but you can see these big clouds of platelets, so definitely a marked thrombocytosis. But remember, we thinking that this lady might be an ET. Just look at these megas. These are small little dwarf megakaryocytes. They're not the big hyperlobated staghorn nuclei you would expect with ET. So already a concern that this might not be a straightforward ET. And under a higher power, you can see there's a dwarf megakaryocyte, small with these loads of platelets coming off it, granular poiesis in all stages. And one of the features of chronic myeloid leukemia in chronic phase is there's not much dysplasia. There's typically no dysplasia in the granules. You may see megaloblastoid change, so giant bands and right shift because just of the excess folate utilization that's going on, but you don't see dysplastic change. And if you are seeing dysplasia, you might consider that this is undergoing clonal evolution. Just a higher power, just showing you the range of cells present. There's certainly megas, there's myelocytes, the whole range of maturation present. And just to demonstrate, under a higher power, there are cells, there are basophils which are relatively prominent on this smear. The trephine biopsy also was not completely typical, not the cellularity we saw with the first patient. You've got sort of low normocellular and mildly hypocellular fragments. Just for the registrars, this bone is slightly osteopenic too, 72-year-old lady. And I've gone into the more cellular region in a zoomed in so you can appreciate the morphology a little bit. And what is noteworthy is these numerous monolobed megas. You can see monohypolobed, but they dwarf, they're small, and consistent with the raised platelet count, but certainly not typical of the non-BCR-able myeloprolifs. You can see that there is retained erythropoiesis, there's granular poiesis in all stages of development. And just because this was quite an unusual presentation, the flow did show no overt increase in blasts, only 0.6%, but a third did show aberrant features. And there was a prominence of basophils with 1.8% basophils present. And the confirmation that this was in fact a CML in chronic phase. FISH showed presence of 922 with the normal transcripts that was present on a myeloid NGS, confirmed the presence of a normal transcript. Obviously, myeloid NGS was indicated in this patient. We were trying to exclude the JAK2s, MPLs, CALR, anything else that might be associated with a thrombocytosis. And the cytogenetics also confirmed the presence of the T922. The only unusual is that this, more typically in CML, it accounts for all metaphases. Here you can see there were some preserved normal metaphases. As in FISH, there were some, only 82 of 130 cells showed the presence of the T922 here. So both these patients did meet the criteria for CML in chronic phase, and just going over just the basics for a little bit more prior to our discussion of the management of patients. So It's a myeloproliferative neoplasm, well known by everyone, characterized by the fusion of the Abelson-Murine leukemia gene, which is ABL1, which is on chromosome 9, with the breakpoint cluster region on chromosome 22. And there you can see the small little pathetic chromosome, which is the Philadelphia chromosome. And this is in obvious cases where you can easily pick it up. And there would be the fusion gene from the ABL and the BCR region. So the mutation would occur within a hemopoietic stem cell or progenitor cell, which is very important for why it has the downstream effects that it does have. It is an initiating event, and as everyone knows, what it results in is a constitutively active tyrosine kinase, a tyrosine kinase that's always on, resulting in multiple downstream effects. Very importantly, uncontrolled proliferation, largely mediated by the MAP kinase pathway, although the others are involved as well. There's aberrant maturation, so we have stem cells with relatively normal self-renewal, but the progenitor cells have increased proliferation, resulting in initiating cells. The cells also manage to escape apoptosis, and the escape from apoptosis seems to be at a fairly high level. It's above the cytochrome C pathway, or the presentation of the pathway. And exactly how BCR-ABL does it is uncertain. There's also altered cell-to-cell interaction, and this is the actual the cell cytoskeleton is abnormal. The bonding of the cells, the adhesion molecules, the cells don't interact as well with the microenvironment or the extracellular matrix, which potentially also leads them to circulate a great deal more, and might also contribute to the proliferative capacity with this abnormal or altered cell-to-cell interaction. This is, again, a very familiar diagram, just showing the fusion protein, which is constitutively active. It's got ATP bound, it's phosphorylating its substrates, and you're getting immense downstream effects as a result of this permanently turned on pathway. And it's mediated by a large number of pathways: the MAP kinase pathway, the JAK-STAT pathway. Obviously, if you're looking at the receptor tyrosine kinases like JAK, can also participate with this BCR-ABL to result in downstream proliferation. You're looking at the SAP-DUNC pathways, as well as the very well-known downstream mediators and oncogenes, cyclin D1, MYC, and STAT5, all of which are activated or have pathways are involved in the effects of CML. So a little bit about the epidemiology and presentation. It has an annual incidence of 1 to 2 per 100,000, but obviously the prevalence has increased with successful treatment. So there are a number of patients being treated currently because of the normalized survival of patients with CML. The classic presentation would be in the 60s, but as you know, it's completely across the age spectrum, from young ages, from children, all the way to much, much older patients. In the USA, about 50% of patients are asymptomatic. However, this is a little bit skewed in our presentation, although we see, and certainly in private practice, a wide range of patients coming from asymptomatic, picked up just on routine films, as patient 2 was, all the way to the most extensive disease with marked leukocytosis of 700, really huge increases. And as I say, they can be asymptomatic or can present with symptomatic features, features of fatigue, weight loss. They can have excessive sweating, features of hypermetabolism, and then symptoms related to that big spleen, so early satiety and left upper quadrant fullness. And at presentation, at least 20 to 40% have a big spleen. And well described, they can either present with a persistent leukocytosis or they may have a persistent thrombocytosis like my patient. And I've seen a number, rarely, that do present with this isolated thrombocytosis. So a bone marrow is for baseline stage. It shows more of the typical features that you'd like to use for the diagnosis. And just update on current classification of 2022, the chronic phase and blast phase are recognized, but accelerated phase has been mutation seen with the tyrosine kinase inhibitors. But it does allow for a chronic high-risk features, so that is still included. And then, of course, you would get the chronic CML in blast phase, and about 2/3 of those would be in myeloid blast phase, where you'd expect a greater than 20% myeloid blasts, but about 1/3 may be lymphoid blast phase. But important to remember that you don't have the requirement of 20% to make the diagnosis of blast phase. According to the WHO, it's less than 10% lymphoid blasts, and the ICC specifies more than 5% lymphoid blasts either in the blood or marrow to make the diagnosis. And there's a further percentage which could be difficult to type. They're undifferentiated or mixed phenotype. Just to highlight that the ICC, in contrast, has retained the accelerated phase group. It's dropped the features like splenomegaly, white cell platelet count, and concentrates purely on the differential counts on blood and marrow, as well as the cytogenetic features. And in accelerated phase, you would get 10 to 19% myeloid blasts, and you would expect the greater than 20% increase in basophils if you're going to go into accelerated phase, along with the additional cytogenetic changes, which are like additional Philadelphia chromosome, trisomy 8, isochromosome 17, trisomy 19, a complex karyotype, or 3q26 abnormalities, all of those which would characterize moving on to the accelerated phase, none of which our patients had. So the diagnosis, it's a prototype disease. It requires the demonstration of the BCR-ABL fusion protein. FISH shows a high concordance between blood and bone marrow. For cytogenetics, the bone marrow is preferred. And when you're trying to determine, the majority have the absolute typical translocation, which is present. But in about 5%, you may get a variant where there's a complex translocation and additional chromosomes are in the mix. So it's not as simple as just the swap between 9 and 22. And in 2 to 5%, you can't see the Philadelphia chromosome. It would be a cryptic translocation, not picked up on cytogenetics. Highlights the fact that frequently other modalities or multiple different investigations are needed to make a diagnosis. But what's absolutely critical about having a cytogenetic sample is demonstration of the additional chromosome abnormalities that you would expect, which have relevance for a prognostication in the setting of CML. Now, for diagnosis and monitoring, PCR, qualitative and quantitative, for monitoring, quantitative PCR is required. The importance of diagnosis is that different BCR-ABL1 isoforms exist because of the difference in the breakpoints in the genes. And certain of these isoforms can't be picked up by the routinely available RT, the quantitative PCR. So it's important to document at presentation what isoform you are looking at. Very commonly in CML, it's P210 transcript, which we all know well. And of that P210, the most typical breakpoints are the E13 or 14 on the BCR gene, and the A2 of ABL, and those would be the classical. They might have some slight therapeutic implication. E13 is supposed to respond a bit more slowly to tyrosine kinase inhibitors, and have a little bit more difficulty in obtaining a deep response. So although that similar survivals have been described between these P210, a minority of CMLs, only about 1%, present with the more typical P190, which you would see in ALL. About 60 to 70% of Philadelphia positive ALLs have the P190, and a very small percentage of CML can show this. These CMLs typically, they might look a bit like a CMML because they're associated with a monocytosis or increased number of monocytes to neutrophils would give you a clue. And they are much shorter transcript. I'll show you where the breakpoint is experienced there. Then you get a smaller percentage of, well, about another 2% variant P210s, which again, different breakpoints, or you can get a much longer isoform, which is a P230, which often is associated with a more prominent neutrophilia morphologically, and potentially some studies have thought a more indolent, but it's uncertain whether this is really the case. These are much rarer translocations. But we have seen patients that look like absolutely classical CML that people have sent, when I remember one well from Zimbabwe, sent upfront BCR-ABL rather than FISH or cytogenetics, and that wasn't picked up until we did the myeloid NGS on that particular sample, and we showed a variant breakpoint which was completely unexpected and wasn't picked up by the gene expert PCR that we were doing for the P210. It was a P210 variant, but it wasn't picked up. And just for illustration, this would be the ABL gene, which contains your tyrosine kinase. Here's the breakpoint cluster region gene, which has got various areas which are where typical breakpoints occur. And that would be your normal one. If it broke over here, you might get a much smaller transcript because that and that are going to be fused. And so those are the variants that you might see. And just briefly, because I don't want to encroach on Yadia's time, monitoring would be performed with standardized quantitative RT-PCR, very importantly adjusted to an international scale. These need to be relatable between various centers so that if the patient does swap centers, that the monitoring is can be carried through, and with the depth of the response is measured on RT-PCR with a deep response at a 4 log reduction, but a major molecular response at a 3 log reduction, and only an early molecular response when you're looking at less than 10%. So very, very critical to be able to get to be able to monitor this patient when the patient's on treatment. Okay, thank you very much.
Thank you so much, Nicole. Sure, that was very thorough and fantastically set out. Thanks so much for that. Yadia, are you ready to share your screen?
Yes.
We'll let Yadia share her thoughts. And
I stop sharing. Okay, thank you.
Yeah, okay, I'm gonna share.
And then we'll take questions. Then.
Oh, hold on. Hi, can you hear me?
Yes, we can hear you. We can't see your screen yet.
Okay, let's try again. Okay, can you see me now?
Looks promising. Yeah, we see Nicole's.
Nicole's, okay, let me go to my section. Sorry. We put our decks together.
Cool.
Okay, so thank you for Hannes for that lovely introduction, and Nicole for a really, really good overview of the pathology and the molecular pathology and the morphology. Just to conclude on Nicole's two cases, the first patient was a young female of childbearing age, and so I decided to start her on a second generation TKI. The second patient was a 72-year-old patient, and as Nicole said, we really thought it was ET at the beginning, but it turned out to be a chronic myeloid leukemia incidentally, and I started her on imatinib. But we'll talk more about why we choose certain TKIs for certain patients and what the current options are for us, both first line and second line and third line. Thank you to Novartis for sponsoring this presentation. My presentation is going to be about discussing the different treatment options that we have available to us, what's available in South Africa and what's available internationally, what investigations we should do before we start a patient on treatment, how to select frontline options, second line options, and third line options.
Yeah,
Then I'm going to...
Sorry for the interruption. I don't know if you're sharing already, but we can still just see Nicole's.
Oh, I can see. Can you not see it? No.
There you can see it. Yes. Awesome. You can just.
Okay. Are you fine now? Can you see it?
Yeah. If you can slideshow, then we're ready. Then
now?
You can go. Yeah.
Can you see it now? Okay.
We can see it. Just click the slideshow again.
Do you see? Okay.
We can see your
Do you see table of contents?
Yes, we can see that.
Okay. So is it fine now, Hannes?
Yeah, it's in PowerPoint, but I mean it's not at the slideshow where it fills the whole screen.
Oh, so wait, let me get there. Sorry.
Start slideshow again.
Yep. Can you see now?
For some reason not. Anyone any questions? Otherwise, you can probably proceed like this if you want to, but it's obviously maybe maximize your screen or go there at the top where it's also a slide screen.
In the top toolbar where it says slideshow, I would click on that.
Okay.
There, left. It is
left.
animations there.
Oh, right. Okay.
Slideshow, yes. And then say from current slide.
Okay.
On the left again, from current slide. There we are.
Okay. Can you see table of contents?
Yeah, but it's not a slideshow yet.
That's very strange. Okay. Nicole,
Again,
do you want to share your
you
slide
need
deck?
to go. You need to go in PowerPoint right at the bottom and just click on the screen. Have you done that, Dr. Marat?
Yep. Yes.
Right at the bottom, clicked on the screen. There are choices. No, down below. In PowerPoint.
Yeah, Nicole, I think it's better if you
Okay,
just
let me share again. Sorry, let me just try.
I'll stop sharing.
Thanks, guys. No worry.
There we go. Is it appearing?
Yep.
Yeah.
Thanks.
Okay.
Yes. Okay. So, where did I stop?
You were busy on that slide, yeah.
Okay.
Sorry.
Okay. So then I'm going to discuss a little bit about asciminib and its role in CML, the relevant resistance testing and mutations in CML, the tyrosine kinase inhibitor toxicity and how we manage them. Also a little bit on treatment-free remission, and then the ask for first trial. Okay. So, multiple treatments are available for chronic myeloid leukemia in the chronic phase. And there are a number of options: first generation tyrosine kinase inhibitors, second generation TKIs, and then other drugs, which we'll discuss a little bit more in detail, like asciminib, which is not a typical tyrosine kinase inhibitor. These are your first line options in your newly diagnosed CML chronic phase patients. Then we have our previously treated patients or our second-line treatment, and this would largely depend on what you used first line or what the patient failed first line or what mutations they have. And then your third line or patients with the T315I mutation, your options being ponatinib, and asciminib. Okay. Nicole, can I control? Oh, okay. Sorry. So just in terms of the recommendations of investigations that we should be doing prior to our starting our TKIs, we need to look at the major side effects that these drugs have. So we need to look at our cardiovascular system, do a basic ECG, make sure that there's no arrhythmias, our lipid profile, HbA1c. We want to make sure that this is either well-controlled diabetic or not a newly diagnosed diabetic, our lipase, amylase, thyroid functions, and then as we go along with treatment, we also need to monitor the patient in terms of cardiovascular, diabetes, thyroid functions, and lipase and amylase to make sure that we're not having toxicity of any of these drugs. So, as I said earlier, asciminib was granted approval by the United States FDA for newly diagnosed adults with Philadelphia positive CML in chronic phase. It is not a typical tyrosine kinase inhibitor. It works a little bit differently. And the choice of the second-line TKI will depend on the reason for changing from prior treatment. So whether it was intolerance or it was a kinase domain mutation, or whether the patient had toxicity. So asciminib was previously indicated for patients who received 2 or more prior lines of TKIs. Now it is approved in 50 countries worldwide for patients with Philadelphia positive CML with resistance or intolerance to more than 2 TKIs. In the US and Australia, it's also, and here and amongst other countries, it's also approved for patients with the T315I mutation. And there's no evidence that switching to an alternate second-generation TKI following failure of a prior second-generation TKI will improve the outcomes, the long-term outcomes. So this is such an important topic and a really important slide. So if you can remember this as a registrar, it's really a lot to take in. But how do we select the best upfront treatment for a newly diagnosed CML with chronic phase? And I think what this diagram, the schematic representation shows us, which is really all your points that you need to remember for an exam question, is what are your patient goals? What are you trying to achieve with the patient? Are you trying to go for treatment-free remission? Is this a young patient who is female and of childbearing age, and you want to aim for TFR, treatment-free remission? Do you want to achieve an early molecular response? Is that one of your goals? And what side effects what comorbidities does the patient have? Mutational status, that will come later on, obviously, depending on whether first line works or not. What prior TKI have they had? The patient's age, again, that's really important because with age, unfortunately, comes comorbidities. And the older the patient, the more likely they are to have hypertension, pulmonary hypertension, cardiovascular risk factors, peripheral vascular disease, diabetes, and all of that. And then other things to consider, your drug interactions, your risk classification at the beginning, like your ELTS and your SOCL score. Were they a high risk at the beginning? This might make you consider starting a second gen upfront. And then again, what can they tolerate? How are their side effects? Are they coping? Because you don't want a case where you're getting great results, but your patient is then falling off the wagon because of poor tolerability and side effects, and their comorbidities are getting worse. And then last but not least, which is quite an important factor, is cost. What can the patient afford? What will the funder give you and authorize? So that's also something to consider. So asciminib is indicated in the treatment of CML. And as I said earlier, it's not a typical tyrosine kinase inhibitor. It works a little bit differently. It has a novel mechanism of action. It specifically targets the Abelson myristoyl pocket, and ATP competitive TKIs inhibit kinases in general, in addition to the Abelson 1, due to the targeting of the highly homologous ATP binding site. Asciminib has specifically for Abelson 1 kinase, and as the structures of the myristoyl pockets of other proteins are substantially different, it is unlikely that asciminib would be able to bind to them with any high affinity. So in newly diagnosed patients who do not achieve optimal responses with the standard TKI therapy, we then look at other options. And long-term use of second-generation TKIs are associated with adverse effects, such as pleural effusions, gastrointestinal events, cardiovascular events. And as I said earlier, persistent adverse effects can lead to poor adherence. And that leads to a compliance issue and can inhibit our patients from taking their medications correctly. This is a diagram I just wanted to show you of the kinase domain and the binding sites. And the tyrosine kinase that we tyrosine kinase inhibitors that we use frontline or even as second line are ATP competitive inhibitors. So they work typically on the kinase domain, whereas asciminib is designed a little bit differently, and it reduces the off-target effects. So there's less off-target and less side effects because of the way it binds. It binds more efficiently and less off-target side effects, leading to less adverse effects. So just another thing about tyrosine kinase inhibitors, we also need to keep in mind that cycling TKIs can lead to resistant mutations, including the T315I mutations. So BCR-Abelson 1 kinase domain mutations are a common mechanism of TKI resistance and have been identified in more than 50% of patients with TKI failure and disease progression. The T315I mutation accounts for 10% to 27% of BCR-Abelson 1 mutations, with 3% to 15% of patients overall developing this mutation, having a chance of having this mutation. In patients in their second generation of TKI treatment, the frequency of a T315I mutation was 9% to 53% in patients with BCR-Abelson 1 mutation and 2 to 14% overall. The T315I mutation is associated with high levels of TKI resistance, and treatment options for these patients are limited. And we'll discuss on the next slide what our options are. So in this slide, I just want to highlight the summary of the pivotal trials that brought imatinib, dasatinib, nilotinib, and bosutinib into the frontline setting. Bosutinib is not available here, but Decision and Ernest End were basically compared to our first line and well-known imatinib, and it was shown that we had better rates of early molecular response and deeper MMR with the second generation TKIs compared to imatinib. So in this slide, I just want to remind you that with the second generation TKIs, so for bosatinib, it's not available here, but if you look at dasatinib and nilotinib, they both fared fairly similarly. And if you look at the bottom diagram, we're looking at third generation TKI, so ponatinib versus asciminib, and you can see that ponatinib had a higher molecular response to asciminib, but we'll have to, ponatinib comes with its issues. And the problem with ponatinib is that it's very rarely tolerated at maximal dose. So usually because of the cytopenias, and especially the thrombocytopenia, you have to dose reduce. It's not a well-tolerated drug. So it makes compliance a huge issue. I put in the slide for registrars going for exams and those who just want to keep a record or look back on this for exam purposes, what doses you might want to, how you might want to adjust your doses of your tyrosine kinase inhibitor, depending on what side effects you have. Just to keep in mind that you should only lower your dose if your patient has already achieved a good molecular response, and they've maintained that molecular response for a while. As I said, with ponatinib, we start at 45, but very rarely have I seen patients, manage at 45 milligrams. And in this diagram, I'm just highlighting the common TKI toxicities that you have with each TKI. So it's really, really important to remember what your side effect profiles are of your first generation, like imatinib, and then your second line, because this will help you further, navigate which choice of drug you're going to give the patient. So I thought this was a really nice summary slide to compare all your TKIs, imatinib, dasatinib, nilotinib, bosatinib, ponatinib, asciminib, and this is one that is only available in China called olveramib. But in this slide, you can see what are your common side effects. So 2 pluses means this is most likely to happen with this particular drug, and a 0 or a 0 is unlikely to occur with this drug. So this is also just for a nice summary diagram. So in terms of our recommended, so in terms of tyrosine kinase inhibitors and their mutations, we know that, for example, T315I is resistant to all our TKIs except ponatinib and asciminib. The other drug that's not in this diagram that does work against T315I is the olveramib, which is the one available only in China. So it's obviously not available to us, but in our setting, your 2 options are ponatinib and asciminib. So depending on what the patient's comorbidities are and what's available to you, these would be your only 2 options. I don't think you can ever be expected to remember this off by heart. I know I can't, but Lancet does provide a nice summary at the end of the molecular response of what this mutation is resistant to and what it's sensitive to. So why is it so important to minimize the side effects? Because we want to improve the treatment goals. We want to make sure that our patient is reaching their optimal molecular targets. We want to make sure that their quality of life is still good, even though they have this major diagnosis of cancer. And we need to improve or take into consideration the adverse effects. And TKIs have lots of adverse effects that lead to intolerance. Fatigue, muscle pain, bone pain, GIT effects that are common with imatinib. Then your pulmonary issues like recurrent pleural effusions that you have with dasatinib. There's cardiovascular effects, thromboembolic effects, and then your cytopenias and your elevated lipase and pancreatitis. So just for some stats, TKIs, TKI class effects, as well as adverse effects, events, are more commonly associated with more than one or more TKI, which can impact your tolerability and your quality of life. Persistent, low-grade adverse events can disrupt the patient's daily life and contribute to non-adherence. Nearly half of patients with CML are not satisfied with their treatment side effects, so that's almost 50%. Adverse events can also lead to frequent treatment switching, such as cycling of TKIs, which can adversely impact survival, which in the previous slide we did say can lead to T315I mutations. Successful adverse event management can make patients more adherent to treatment, improving both clinical outcomes and quality of life. Adverse events management need to be individualized to help patients stay adherent. Sorry, this one I've already discussed. Just gonna move past this. Okay, so TKIs are essential in treating patients with CML, but their use is associated with specific adverse effects. Common hematological toxicities are cytopenias. Non-hematological adverse events include liver enzyme derangement, electrolyte derangement, fatigue, and a whole list of other comorbidities, side effects, which we'll discuss later. But how do we select the patient? And as I said earlier, you look at age, you look at comorbidities, you look at cost, you look at drug interactions. And this is a really, really cute diagram, which just gives you the really, really common ones that are associated with each drug. So the things that you really have to know, like the back of your hand, and imatinib can give you fluid retention, myalgia, GI effects, and a rash, which is not in here. But dasatinib, pleural effusions, pulmonary issues, pulmonary hypertension, nilotinib, which is your prolonged QTc interval, high sugars, elevated pancreatic enzymes, ponatinib, again, hypertension, cardiovascular and thrombotic events and cytopenias, asciminib, diarrhea, nausea, and a rash. And then common to all of them would be myelosuppression, electrolyte abnormalities, and fatigue. So ATP competitive TKIs, which are our imatinib and our second generation, have off-target effects. And these off-target effects can cause intolerance to the drug. And this is where asciminib is a little bit different because it has less off-target effects. And that's important to understand when you are choosing a drug up front. So don't get me wrong, I'm not saying that there's a space for asciminib upfront for every patient, but in a subpopulation, it is a consideration. So protein kinases are involved in many diseases, such as cancer and inflammation, and are important targets for drug development. ATP competitive TKIs are approved for CML therapy, and they bind to kinases in addition to their intended target. Most kinase inhibitors target the kinase ATP site, allowing the potential for cross-reactivity. Off-target binding can modulate unintended biological pathways and may contribute to the short and long-term safety profiles of TKIs. This is also a really nice diagram to have for exam purposes, just to remind yourself of what the baseline comorbidities in each that could affect your choice of each drug. And if color diagrams work well for you, I think this is quite nice. So in red is obviously for danger. So if it has a red block next to it, please avoid it. Do not choose that TKI up front. the intolerance of patients with intolerance as a primary reason for stopping or discontinuing a TKI was studied and followed up, and discontinuation of due to adverse events in CML trials over time was looked at, and you can see follow-up 1 to 10 years, and the most follow-up we have is for imatinib and nilotinib, and you can see in this diagram, and then less for the second generations like ponatinib, but according to side effects, you can see that imatinib had the least amount of discontinuation due to adverse effects compared to the second generation and third generation TKIs. Okay. I just want to skip the slide because I've shown you something similar before. Okay, so treatment cycling, this is a study that was showing us what's more common. Is it resistance, kinase domain resistant mutations, or is it intolerance that drives us switching treatment regimens? So one might have thought that it was resistance mutations that's a more common cause of switching TKIs or treatment, but actually in the diagram you can see that it was actually intolerance that was more common as a cause of changing to second-line treatments. So in the blue blocks, you're looking at your resistant percentages, and in the red blocks, you're looking at your intolerance percentages, both in first-line, second-line, and third-line treatment. So you can see your red blocks, which is intolerance, are far bigger proportion compared to your resistance proportions. Okay, so now we're just going to talk a little bit about treatment-free remission, a really topical talk at the moment, and is a talk of its own, but just to highlight that there's two different categories or criteria depending on what you read for treatment-free remission and when to discontinue TKI. I put them both in because it doesn't matter which one you quote as long as you quote one correctly. This is the NCCN and this is the ELN guidelines. They're fairly similar. The only major difference is ELN is a little bit more stringent, but essentially very similar. Now, a little bit about asciminib and why it's recently been approved as in the first line setting for chronic phase CML. I'm going to just discuss the Ask for First trial a little bit. And this was a phase 3 open label, multi-center randomized study of asciminib versus investigator-selected tyrosine kinase inhibitors as first-line therapy in patients with newly diagnosed Philadelphia-positive CML. This is the first study and only study assessing a novel drug for first-line use in patients with newly diagnosed CML that uses all other therapies currently approved for this indication as comparators, so both first and second generation TKIs. Asciminib was started at a dose of 80 milligrams daily, and the approved ATP competitive TKIs was started at their approved doses. The goal of the study was to assess the efficacy and safety of asciminib versus approved ATP competitive TKIs in the first line. Okay, so in this slide, we can see what the inclusion criteria were. So newly diagnosed Philadelphia positive CML patients with no previous TKIs, patients over 18 years old, and they were randomized and then again stratified according to their risk score, and there were two arms, one with asciminib versus imatinib and a second generation, and then all your TKIs versus asciminib. So the primary objectives of the ASC trial were met with high statistical significance. Asciminib demonstrated superior major molecular response rates at week 48 versus all the investigator-selected tyrosine kinase inhibitors. Asciminib demonstrated superior major molecular response rates at week 48 within the imatinib stratum. Asciminib had higher rates of early and deep molecular responses and a markedly favorable safety and tolerability profile at week 48 versus both imatinib and second-generation TKIs, which implies probably a better side effect profile. So I just wanted to show you that most patients on the trial, comparing asciminib with all investigator-selected TKIs, the median duration of follow-up was 16 months with asciminib and 15 months for the TKIs. But you can see that the number of patients in the asciminib group that discontinued treatment was much lower than the TKI group. In this diagram, we can see that the major molecular response rate at week 48 was superior with asciminib versus investigator-selected TKIs, which met the primary endpoint. So you can see here that the major molecular response rate was much higher in the red graph, which is your asciminib, versus all your other investigator-selected TKIs. And this is major molecular response at week 48, and then your early molecular response at 12 weeks, and then your molecular response log 4 and 4.5. So there was definitely a significant reduction at week 48. So in this diagram, they're showing a higher response of molecular deep and early molecular responses in the asciminib group that was compared to the imatinib group. So there was a stratum of just asciminib versus imatinib, and you can see that the patients on asciminib had a far better molecular response, both early and deep. This is a diagram showing us the non-hematological toxicities of asciminib, and we can see that they were much lower compared to imatinib and your second-gen TKIs. So asciminib is your first column, and we can see our GIT side effects, which is much lower. For example, if you look at diarrhea, you're looking at 15%, constipation 9%, nausea 9%, which is much lower, and then your constitutional side effects, and then your laboratory. But if you can compare in general, asciminib was much better tolerated in terms of non-heme side effects. So in conclusion, the advent of tyrosine kinase inhibitors targeting BCR-ABL1 has led to a life expectancy for patients with chronic myeloid leukemia that is similar to the general population. For patients with newly diagnosed CML in the chronic phase, ATP competitive TKIs are approved for first-line therapy, imatinib, and then second-generation TKIs. Whereas these TKIs function through the same mechanism of action, they have different target profiles and associated with different molecular response rates and safety profiles. Response rates are similar among second-generation TKIs, but higher with second-generation TKIs versus imatinib, with major molecular response rates ranging from 74 to 77% and 60 to 65% respectively by 5 years. Despite the interventions, 35 to 40% of patients will require a change of therapy within 5 years. Asciminib has demonstrated a favorable efficacy and safety in phase 3 clinical trials in patients with CML chronic phase who have received more than 2 or more prior lines of TKIs, and in a phase 1 clinical trial in patients with chronic phase CML or accelerated phase with and without a T315I mutation, and who have received 2 or more or 1 or more prior lines of TKI respectively. Thank you.
Sure. Thank you, Yadia. That was a mouthful. Very
Sorry,
thorough.
Hannes.
It's fine. Yeah, anyone, any questions? Don't leave me hanging. Any questions for either Yadia or Nicole? Creak, creak. Just a couple of comments from my side. I must say, and maybe, you know, if Cecile or Myrtle that's working, or any one of our state colleagues are still here, maybe they can comment. You know, the intolerance is really actually quite a thing, you know, and I didn't realize it when I was still a fellow, and now that I've worked with a lot of CML patients, is, you know, the TKIs are really not without issues. You know, not even, you know, and even if it's not just the, you know, big pleural effusions or vascular events with nilotinib or whatever, you know, just a lot of them just say they're just feeling off. They're just not feeling well, whether it's low-grade headaches or whether it's just mild gastrointestinal side effects. So intolerance is actually quite common. Would be interesting for me is and again, maybe one of our state colleagues can comment. Is it as common in the state sector? Because my experience, state versus private, when I still, you know, worked in the state sector with, say, lymphomas receiving chemotherapy, and yes, it might to a degree be a younger population, but that it's almost as though the patient in the state tolerated some of the chemotherapies and things much better. And one can, you know, reason with regards to why is it, you know, it's people that are more often manual laborers, maybe fitter, more used to, I don't know, eating up things and just doing what the doctor says and questions things less. But it's almost as though, you know, people here in private tolerate things less. Any comments from our state colleagues? You know, do you also see such a lot of intolerance as you know, that we see in the private sector? Are you going to leave me hanging again?
Okay, Hannes, I'll comment. So I wasn't in the private sector too long ago, so I can comment. You know, I think we didn't have many options in the in the public sector. So it was imatinib, or, you know, you could motivate for a second gen if there was resistance, or patients weren't failing their or patients were failing their molecular targets. But I did have a chance to use ponatinib, which patients complained bitterly about, and very few of them actually tolerated them because of their thrombocytopenia. In terms of the imatinib, though, I feel like with the state patients, and I'm not sure yet about private patients, but I feel with the state patients that over time, the imatinib side effects improved. So initially, there's a lot more complaints, and with time, I'm not sure whether people just become accustomed to a new standard of living, or new, but there were less complaints with time. That was my experience.
In general, most of the TKIs, the first 2-3 weeks, there's more intolerance, and then sort of try and push through, and then a lot of it settles. But there's just some patients that just never lose some degree of that. Any other comments? Myrtle from Grooteskier says she agrees. What was interesting for me also from the CML talk that we had this weekend at Hem-Onc was, you know, we were always taught, and it's obviously very important still, is, you know, compliance is so important, and if you miss more than 2 doses per month, then the chance of resistance exponentially goes up, etc. And interesting what he mentioned is, you know, when we were speaking about the lower doses of especially the dasatinib that can be used, is that they've had this trial where they just give dasatinib 70 milligrams from Monday to Friday, and then give them a break on a Saturday and Sunday, and that it actually had similar outcomes to the people who just took the 100 milligrams every day, which is something to get used to. You know, if missing 8 doses a month in that setting doesn't do much, then you wonder how non-compliant are people really if they start to progress because of non-compliance. But that was quite interesting for me. Any other questions from the floor? They both gave such thorough talks that there's all the questions have been answered. All right. So if there's any no other questions, we are over an hour, which means that everyone that joined would get their more than an hour CPD points. Again, Nicole, Yaria, thank you so much for really very comprehensive talks, very informative. Thank you everyone for joining. Until next week, with regards to the anemia and apheresis talk, I hope you guys have a great week. And we see you all again.
Thanks, Hannes.
Cheerio.
Bye-bye.
Bye.